Bismillah ar-Rahman ar-Rahim, MRI of benign and malignant breast lesions. Over the past few years, there has been significant development in the investigation and management of breast cancer, because it was found that the only way to curtail breast cancer is by coupling early detection together with proper diagnosis in order to be able to give the patients the most adequate and appropriate treatment options. And of course, we as radiologists play a fundamental role in this part. We all know the difference between detection and diagnosis, where detection means finding unsuspected pathologies, and that's what we actually do in screening programs. Diagnosis is moving another step forwards and trying to classify these pathologies into benign and malignant. And for long, we've been using mammography as a detection modality, and it was coupled with the ultrasound to improve its diagnostic capabilities in order to yield the best outcome. And when MRI was first introduced, it was thought that it will play its main role as a diagnostic modality. Until recently, according to the ACR guidelines, MRI is also used as a screening modality, especially for high-risk individuals. Looking at the indications of MRI as a detection modality, as we've just said, it is used in screening of high-risk individuals, and as a diagnostic modality, it should be used whenever we have inconclusive mammography findings, in the preoperative staging, whenever we have metastasis of unknown primary, to monitor chemotherapy, in the post-operative breast, and whenever we have fixed breast implants. A contrast-enhanced MRI has an advantage over other breast imaging modalities. It can combine both morphology assessment together with giving functional information. And under the morphology assessment, we are going to discuss the MRI morphology descriptors, and under the functional information, we're going to discuss the MRI kinetic curve analysis. And we're going to use both in order to discriminate between benign and malignant breast lesions. And at the end of the lecture, I'm going to give a brief account on how can we write an MRI structured report. We'll start by giving a brief hint about the MRI technique. We all know that females are subjective to hormonal changes during the menstrual cycle. Immediately after menstruation, the pituitary gland secretes the FSH, and from its name, follicular stimulating hormone, that means it will go to the ovary and stimulate the follicles within the ovary to grow. In the first half of the cycle, the estrogen takes the upper hand, and the estrogen has a proliferative effect on all tissues, especially the lining of the ducts and the lining of the endometrium. In the second half of the cycle, after ovulation, the corpus luteum starts to secrete progesterone, and this progesterone makes the cells loose from each other, and that is the reason for why females feel premenstrual tension in their breasts. So if we ask when to perform an MRI examination, as we've just said, all women experience changes in their breasts throughout the menstrual cycle. Increased parenchymal enhancement has been observed normally during the secretory or the second phase of the menstrual cycle. MRI imaging at that time can result in strong glandular enhancement, complicating the interpretation of the images, and can increase the number of false positive and false negative results. So the best timing to perform MRI study is immediately after menstruation. Another important timing is when to perform MRI after surgery or after radiation. We should wait at least 6 to 9 months after therapy before doing an MRI. Before performing breast MRI, it is important to inform the patient that lying comfortably and motionless is important for successful imaging of the breast. The patient should be instructed that administration of the contrast agent can result in various physical sensations, which may cause patient anxiety and motion when not properly instructed. The patient enters the gantry head first in the prone position with the breast hanging in the radiofrequency coil. Her arms should be by her side, and we should put cushions under the legs to make her comfortable. and then we center the laser beam localizer at the center of the chest. To further reduce motion artifacts, the breast can be gently fixed using cushions, and that is especially if we have small breasts. Excessive compression should be also avoided, as this might influence breast perfusion and thus contrast enhancement pharmacokinetics. We have to know that proper positioning means that we should have no skin folds. This is an example of an improperly placed breast where the breast was misplaced, and here we see the reflection of the skin fold. And these are two examples of extensive compression of the breast, and this is an example of a small breast which was not adequately supported, and so we have motion artifacts. In the pre-contrast sequences, we take an axial T1 weighted image, an axial T2 weighted image, an axial T2 stir weighted images, and in some centers they also prefer to take a sagittal T2 weighted image. We plan the axial slices on the sagittal localizer, and we get images that look exactly like the CC view. And we plan the sagittal slices on the axial localizer, and then we get images which look exactly like the mediolateral view. In the post-contrast dynamic sequences, we inject gadolinium at a dose of 0.1 millimole per kilogram. And then we take a sequence of images starting by 0 up to 8 minutes. If we look at the post-contrast images, for example, if we imagine that this is the T1 pre-contrast image and this is the T1 post-contrast image, and then we're looking on a white enhancing lesion within this white appearing breast. And that's why we have to image the post-contrast sequences either in the fat suppression or in the subtraction mode. Fat suppression is a generic term. Hydrogen nuclei of fat and water resonate at different frequencies, so we depend on the fact that there is a possibility to selectively excite or suppress just the fat. Image subtraction is another technique. It is removing the background signal from pairs of pre- and post-contrast images. Much of this background signal is fat. If we imagine that these are the post-contrast images, and then we're trying to look for this subtle enhancing lesion within this white breast. But if we subtract the non-contrast images from the contrast images, then we're only left with the newly enhancing breast lesion. Non-enhancing lesions of the breast are usually benign, and we have only a few malignant lesions which do not show enhancement, and the most famous of which is the DCIS. On the other hand, enhancing lesions might be are usually malignant, they might be benign, and we have also normal enhancing tissues with normal tissues which might show contrast uptake. And now we'll start discussing the MRI morphology descriptors and the kinetic curve analysis. After finishing the MRI technique, we're given about 6 to 8 films, and then we feel we are in a mess, where to start and what to look for. We have to know that enhancement of a lesion on MRI depends on its neovascularization, and it is rare to find non-enhancing malignant mass lesions, as we've just said. So it's reasonable enough to start by looking at the post-contrast subtraction or the fat suppression films. If we do not find any enhancing lesions in these films, then we have an easy job. We have to go back to the T2 and the T1 weighted images, trying to characterize lesions which do not enhance, for example, cysts or areas of fat necrosis. While if we have enhancing lesions, then we have a long job to perform. We have to assess the morphology descriptors of this lesion. We have to measure the kinematic curve, and we have to look at the T2 and the T1 weighted images. And remember, whenever we are looking on the MRI, you should always have the mammogram in hand. And now we'll start by discussing the morphology descriptors of enhancing lesions. According to the MRI lexicon, enhancing lesions are classified into focus, which are lesions less than 5 millimeters and they are non-space occupying. Mass, which is a three-dimensional lesion, it is space occupying, and non-mass, which is an area non-space occupying. Looking at enhancing foci, as we said, they are lesions which are less than 5 millimeters. We might either have a single focus or multiple foci. And according to the MRI lexicon, multiple bilateral enhancing foci should be considered background parenchymal enhancement. And now we move to the enhancing mass lesions. And enhancing mass lesions, as we've just said, might be benign and might be malignant. And so to characterize enhancing mass lesions, we should describe their shape, their margin, and the internal enhancement characteristics. As regards the shape, the lesions might be either rounded, oval, and these are both considered descriptors of benign lesions, and they might be irregular, and this is considered as a descriptor of malignant lesions. Formerly, in the past lexicon, we had a lobulated shape, but this was removed from the new lexicon. Looking at the margins, we might either have circumscribed margins, and this is considered as a descriptor of benign lesions, and we might have not circumscribed margins, which might be either speculated or irregular, and they are both descriptors of malignant lesions. And then we have to look on the internal enhancement characteristics, which might be either homogeneous or the lesion might show dark internal septation, which is characteristic for fibroadenomas, and these are both descriptors of benign lesions, or the lesions might either show heterogeneous enhancement or a ring enhancement pattern, and these are both descriptors of malignant lesions. And now we're left with looking at the enhancing mass lesions. To sum up, they might be benign and they might be malignant. If they show, if we look at the shape and the margin and the internal enhancement pattern, and then we have a rounded or an oval shape, a lesion which has circumscribed margins, it shows homogeneous enhancement or dark internal septations, then most probably this lesion is a benign lesion. While if we have an irregular shaped mass lesion which has a not circumscribed margins, which might be either irregular or speculated, and it shows a heterogeneous pattern of contrast uptake or a rim enhancement, then most probably it is a malignant lesion. We also have to put findings together and take by the worst sign. For example, this lesion can be described as rounded, it has not circumscribed, speculated margins, and it has a homogeneous pattern. So it has two signs which denote a benign nature and one sign which denote a malignant nature. We just ignore the benign, the rounded shape, and the homogeneous pattern, and we take by the worst sign, which is the speculated margins. And now we're left with the non-mass lesions. And as we've said that the non-mass is an area, it is non-space occupying, it's exactly like getting a brush and painting on a paper. Again, non-mass lesions might be either benign and might be malignant. And for characterizing non-mass lesions, we have to describe the distribution, the symmetrical or non-symmetrical, and we have to describe the internal enhancement patterns. We have to always remember that bilateral symmetrical non-mass enhancement is almost always benign. It is usually enhancing breast parenchyma. Looking at the distribution of non-mass lesions, it might be either focal, linear, segmental, regional, which is an area which is more than a segment, multiple regions, or diffuse parenchymal enhancement. Asymmetrical non-mass enhancement, on the other hand, is almost always of concern. They usually indicate an ongoing underlying pathology. Looking at the internal enhancement pattern, this might be either homogeneous, heterogeneous, clumped, or clustered ring. And with the exception of the homogeneous, the other three patterns usually indicate a malignant nature. And now we've finished with the morphology descriptors and we move to describing the kinetic curve analysis. The time signal intensity curve on MRI has two phases: an initial phase, which might be either slow, medium, or fast, and a delayed phase, which might be either persistent, plateau, or washout. We should also note the peak of contrast uptake in the curve of the curve. And this peak is usually measured at about 3 to 4 minutes. Doing so, we have different types of curve. A type 1 curve is a typically benign curve. It is this light violet curve. It is a continuously rising curve. A type 2 curve is a borderline curve, or what we know as the plateau curve. It is this green curve, and it is 50% benign, 50% malignant. A type 3 curve is a washout curve. It is this red curve, and it is typical for malignancy. And we have a low peak curve, which is due to parenchymal enhancement. After looking at the morphology, the kinematic curve analysis, we have to look at the T2 and the T1 weighted images. The T2 weighted sequences is often known as problem solver sequence, since it provides additional relevant information on different breast lesions, narrowing down the differential diagnosis consideration. If we have a bright signal on T2 weighted images, that means we have good news. It might be either a cyst, a lymph node, or a fat necrosis. While if we have, and only colloid carcinoma is bright on T2. While if we have a dark signal on T2 weighted image, that means we have bad news. One important factor that we have to look at the T2 weighted images is when we encounter rim enhancement on MRI. These are two different examples of lesions showing rim enhancement on the post-contrast subtraction images. We have to go back in these cases to the T2 weighted image. If the T2 weighted image shows an underlying dark lesion, then most probably this is a malignant lesion, while if the T2 weighted image shows an underlying bright lesion, then this is an abscess cavity. This is another example where we can make use of the T2 weighted image. This was a young female. She came with inflammatory changes of the left breast. She had skin edema, and she had an area here which showed segmental non-mass enhancement. On measuring the time signal intensity curve, we had a continuously enhancing curve. So we have segmental, heterogeneous, yet benign curve, and in this case, actually the case was an unreliable curve. Going back to her T2 weighted images and looking at the corresponding area on the T2 weighted images which showed the contrast uptake, this area was dark and the biopsy was taken, and this was a case of an inflammatory breast carcinoma. We also have to report for other findings. For example, in this case, we have a shrunken breast with skin thickening and nipple retraction. We should report for the presence of pathological lymph nodes. We should also mention the presence of fat necrosis and seroma, and these are usually assessed on the pre-contrast images. And this was an operative bed. This is the seroma with an adjacent area with fat necrosis. And one very important thing that we should report for is the affection or the invasion of the pectoral muscle. And remember, you should always have the mammogram in hand. For example, this is one of the worst types of breast you can ever encounter. This is a very dense, heterogeneously dense breast, but looking closely on her breast, there was here a cluster of microcalcification in the left breast. During the MRI, there was a corresponding area of linear oral enhancement, and the biopsy was taken, and this was a case of GCIS. Another option on MRI which proves the specificity of MRI is the MRI spectroscopy. In spite of the fact that MRI shows very high sensitivity in the detection of breast lesions, its specificity remains relatively low, resulting in many unnecessary biopsies of benign lesions. Studies of experimental breast tumors have shown that choline is elevated in malignant lesions. The raised choline values may be detected in vivo using single voxel MR spectroscopy. Magnetic resonance spectroscopy can be performed along with MRI to obtain information about the chemical content of breast lesions. This information can be used for several clinical applications, such as monitoring the response to cancer therapies and improving the accuracy of lesion diagnosis. For example, this was a young female. She was diagnosed on an ultrasound examination as having a right breast adenoma. There was a large mass here deeply seated in the right breast. And when looking on the T2 weighted images, this lesion showed a more or less bright signal on the T2 weighted image. On doing MR spectroscopy, it showed a high choline peak suggestive of malignancy, and the biopsy was taken, and actually this was a case of a triple negative invasive duct carcinoma. Another option also used on MRI is the diffusion weighted imaging, which provides a novel in MRI imaging and has a high sensitivity in the detection of changes in the local biological environment. A significant advantage of diffusion weighted MRI over conventional MRI is its high sensitivity to change in the microscopic cellular environment without the need for intravenous contrast material injection. On the diffusion weighted MRI, we usually look at the diffusion weighted images. We usually measure the ADC value, and we have to look back at the T2 weighted images. This is an example of a 47-year-old female who presented by palpable left breast mass. Her mammography showed inconclusive findings. Her MRI also showed an inconclusive, deeply enhancing mass lesion in the left breast. This mass appeared dark on the T2 weighted images with prepectoral edema, but it appeared more or less circumscribed. On measuring the time signal intensity curve, it showed a plateau curve or a type 2 curve, which is 50% benign and 50% malignant. Looking at the diffusion images, the lesion appeared dark on the B0, B50, and 850. And when measuring, that means it is restricted. And when we measured the ADC value, it was 0.7. That is a low ADC value because the cutoff value between benign and malignant is around 1.2. And so a biopsy was taken, and this case was an invasive duct carcinoma. And now we're left in the lecture with the MRI report structure. The MRI report should include the indication for examination, the MRI technique, a description of the overall breast composition and background parenchymal enhancement, a clear description of any important findings, comparison to previous examinations, a final assessment category, and a recommendation for management. And actually, we've discussed most of these points. We're left with the description of the breast density, comparison to previous examinations, the final assessment category, and recommendation. The first step is that we have to describe the overall breast composition, and this is usually done on the T1 and the T2 weighted image, where this is considered as an almost entirely fatty breast. This is a scattered fibroglandular densities. This is a breast with a heterogeneous fibroglandular parenchyma, and this is an extremely fibroglandular parenchyma. And then we have to go to the subtraction images to assess the amount of background parenchymal enhancement. And this might be either minimal, mild, moderate, or marked. And we always have to remember that whenever we have bilateral symmetrical background parenchymal enhancement, that means we are dealing with enhancing parenchyma and not specific lesions. We also have to compare with previous studies. For example, this was a young lactating female, and we know she's lactating even without her history from this amount of enhancing glandular parenchyma. Her left breast was shrunken with skin edema, coarsened trabeculae, and she had a huge infiltrating mass lesion which occupied most of the breast. On measuring the time signal intensity curve, the lesion showed a type 3 washout curve, which further confirmed its malignant nature. She received a neoadjuvant chemotherapy, and she came to assess for the response of therapy. We have less parenchymal enhancement than we used to have, and we have less skin thickening or almost total resolution of the edematous changes. And on plotting the time signal intensity curve, she even showed the type 1 curve, and these findings collectively indicate very good response to treatment. At the end, we should classify the lesions by giving them a BI-RADS category, where a BI-RADS 0 is an incomplete assessment that needs additional imaging evaluation. A BI-RADS 1 is a normal examination, there is nothing to comment on, and the routine MRI screening is recommended only in high-risk patients. A BI-RADS 2 is a benign finding, and routine MRI screening is recommended in high-risk patients. A BI-RADS 3 is a probably benign lesion, and the short interval follow-up is suggested. A BI-RADS 4 is a suspicious lesion, and tissue biopsy should be considered. And in MRI, we do not divide the BI-RADS 4 into A, B, and C. It's just the BI-RADS 4. And the BI-RADS 5 is a highly suspicious lesion of malignancy, and tissue biopsy should be considered. A BI-RADS 6 is a known biopsy-proven malignancy, and surgical excision is recommended when clinically appropriate. And thank you. Alhamdulillah.